Coba ya tahun berapa? Udah bisa mulai? Okay, good morning. Good morning, everybody. His Excellency Minister of Health, Bapak Budi Gunadi Sadikin, Assistant Director General for Universal Health Coverage Life Course, Dr. Bruce Elwood, and Anna Stavler, President of WONCA, USAID Assistant Administrator for Global Health, Dr. Atul Gawande, Mr. Surak Wisetsak, Director General of the Department of Health Service Support, Ministry of Public Health of Thailand, and Dr. Innocent Bergier from Uganda, and also Director for Bersur Center Canada, joining us online today, and also all the distinguished guests, ladies and gentlemen. Welcome to the side event of the 76th World Health Assembly, the road to transformation of health, integrated primary healthcare, and the role of family medicine. Ladies and gentlemen, this meeting today, we are having this meeting today as part of the unofficial side event of the 76th of World Health Assembly. We want to use this momentum so that we can all gather and sharing our experience, our knowledge in terms of primary healthcare, especially the role of family medicine. We invite all the participants, all the experts that already attend here or virtually to share your knowledge, your experience in your countries or in your organizations in developing the integrated primary healthcare services and the role of the family medicine. We will begin this event this morning with a remarks from His Excellency Minister of Health of Indonesia, Mr. Budi Gunadi Sadikin.
My friends, Bruce, Atul, and Ibu Anna, ladies and gentlemen, my deepest apology, I'm running late to this meeting. I tried to wake up in the morning because just arrived yesterday afternoon from Indonesia, and I think I'm a little bit jet lagged. But I just want to share with you, I'm not a health professional. I'm a nuclear physicist by training. I spent 30 years in banking, running the biggest bank in Indonesia, and suddenly God knows why the president chose me to become the Ministry of Health. So to be honest, when we are talking about health, then I'm the least knowledgeable person in this room compared with you all. Yeah. And when I joined on the 23rd of December 2020, the president asked me to execute the vaccinations and control the pandemic. I'd like to say with you that when I see the budget, I'm a finance person, see the budget first. 80% of my budget is about curative programs to cure sick people. And 80% of my time on the first 3 months is also working about hospitals, doctors, how to cure sick people. So I'm asking my colleague, hey, my name is Minister of Health. Why I'm managing sick people more than keep them healthy? So I think we have to change the name to Minister of Sickness rather than Ministry of Health. So then I start learning about it's actually keeping people healthy. It's much more financially, again, I'm a finance person, financially it's more justified from any government in the world. And also is a better quality of life for all people. I learned about SDG 3 to promote healthy life and well-being for all people and all ages. I tried to find cure sick people, I couldn't find it. And then I realized that because during the last 30 years, Indonesian health minister is coming from a doctor. Then I realized doctors spend 10 years, 15 years of their life curing sick people. So there is a tendency that will be the program, which is okay. But then I realized that the first 3 months, I have to, move the needle and spend more time in keeping people healthy, not to cure sick people. That's why I'm a very primary care person, actually. Then we start with revamping the reform in the primary care. We have 300,000 posyandu, the smallest unit, 10,000 puskesmas plus 13,000 primary private clinics, so 23,000 in all of our district. And we have 514 cities. We have 34 provinces. So one of my first priority is to revitalize these whole systems. Indonesia in 1968, 10 years before Alma Ata, we established this puskesmas, 10,000 puskesmas. And then in 84, so around 6 years after Alma Ata, we expand to 300,000 posyandus, because to serve 270 million Indonesian people in 7,000 islands, I learned it from a tobacco company and a retail company, because I used to lend money to them. I feel guilty now. You know, what happened is, these are the products that can reach 200 million Indonesians very, very fast. I realized I learned from the Unilever, I learned from the Procter & Gamble, from Coca-Cola, from Indofood, from the cigarette company, why you can sell your products quickly to hundreds of millions of Indonesians. The reason is they have a very fast distribution network called a warung, a traditional shops, that is the minimum is 300,000. As a banker, I know. So then I realized if you want to deliver any kind of product and services to 7,000 inhabited island, 270 million people, if you only have 10,000 puskesmas, forget it. If you even put an angel to do it, they will never be able to do it. So you need an extension. So I'm very surprised, but during the Suharto regime, they established this Posyandu community workers group. Each posyandu 300,000 have between 5 to 10 people. So there are 1.5 million to 3 million community workers across Indonesia that can do primary care services. So part of my program, the first one is to revitalize this network. 300,000 posyandu, 10,000 government-owned puskesmas with 13,000 private clinics, and then 514 cities, dinas and office of health, and then the 38 provinces, revitalize them, standardize the service, change that before only for babies and pregnant mothers to all life cycle. Before, the posyandu is only focused on delivering babies and pregnant mothers, but now it's for life cycles, children, adult, and old people, and then focus on educations, screening, and surveillance. So we push the digital platform down to the posyandu. We push the rapid test technology down to the posyandu level, and then puskesmas we put labs, just to do a public health lab functions, and 10,000 puskesmas. So that is what we do: revitalize the posyandu puskesmas by standardizing and enhancing their healthcare services, mostly promotion and prevention, and then we provide with the facilities, digitalize them heavily, and also after that, we provide with the people and train them, which is the most difficult part of it. Now we need the money. So we work. I learned as a banker that looking for money as a banker is not a difficult thing to do, especially in health sector, because everybody feel, what do you call it? We need to help them. We need to help this guy. So hopefully next month we will close the multilateral loan from ISDB, World Bank, ADB, AIIB for $4.2 billion. My Minister of Finance said this is the biggest ever the multilateral agency financing government program for, do all of this, the $4.2 billion to revamp the network, train the people, equip with the equipment, and also establish the public health labs across the country. And hopefully that will enhance the promotions and the preventions program of this month. Now, related with WHA, because I realized when I plan to do it, then I realized that we don't have enough doctors. We have 270 million populations. The active doctors working is only around 160,000. So less than 0.5 doctors for every 1,000 people. When I Google World Health Organization, World Bank, I see average developing country is 1 for every 1,000. If I go to developed countries, sometimes they get 3, sometimes they goes up to 4. We only 0.5. So that's why, and I'm very surprised when I noticed that we have a moratorium in opening a new faculty of medicine. Why we have less doctor, but we have moratorium? Then I understand now the politics in doctors association, and all of those things. And because they save many lives, including politicians, the law that we have now is very, very protective. Even for an Indonesian people, Indonesian citizen, graduate from Harvard Business School, working in a Mayo Clinic and become a department head in Mayo Clinic, when he want to come, you cannot practice. Because you never seen malaria in Mayo Clinic in United States. So you have to go to Papua for 2 years to learn about malaria, which is, I think, is very ridiculous. So we are very protected. That's why now I'm embarking the first and the toughest ever political job. So I will reform 11 law related with health into a single health law. And hopefully by June, it'll be finalized. It will put more emphasis into primary care. It will open up the provisions of medical professionals in the country. If we don't have it, we can import the doctors to come in, and it will also facilitate the development of the future technologies like healthcare information technologies and also biotechnology in the futures. And hopefully we will get more doctors. So I'd like to close my speech now that, again, I'm managing wealth. Now I have to managing health. You know, when I talk about health, it is like the survival of the fittest. And when I joined, I realized that in Indonesia, it's the survival of the wealthiest. Only wealthy people can have good access of health. Go to Singapore, go to other country. I think my job, I want to leave a legacy. So health is not survival of the fittest or survival of the wealthiest, but it is survival of the poorest, survival of the most sickness. And that is our ambitions, to make sure that all Indonesian people can have a healthy life and well-being. And I realize, and I will share with you, that 30 years in banking and 2 years as Minister of Health, now I strongly believe that the best wealth is health. Thank you.
Next, I will call Dr. Bruce Elworth from WHO to speak about the reorientation of primary healthcare towards a stronger primary healthcare system from a global perspective. The place is yours.
Thank you very much, Sarah. And thank you, Minister Budi. I want to thank Minister Budi both for bringing us together on this crucial issue, but also for giving my speech. So with that, I'd like to thank you very much, and I can sit down because but in seriousness, our goal here today was really come together, share some experience on this crucial issue of how do we transform health systems really toward a primary healthcare agenda. I was a little bit concerned when you got up, Minister Budi, though, and said that you're the person in the world who knows or in the room who knows the least about this agenda, because I've been in this job now for, I think, 5 days. And so I was thinking I was the one least informed, and certainly learned a lot just listening to you. So thank you for that. Ladies and gentlemen, as introduced, my new role now is to help drive the agenda at WHO around reorienting our UHC work on primary health care. And this is going forward the top priority of WHO. We have a 5-year agenda in front of us, 5 big, ambitious, tough goals, but number one among them is the reorientation around primary health care. And the reasons behind that, just to say a few words to that effect, is first of all, a little bit like you alluded to, Minister Budi, 90% of the essential interventions across the life course can be delivered at the primary healthcare level. So it just makes sense from that side. And there's a staggering statistic I saw the other day that still baffles me a little bit. And I really want to see what's behind it. But if we were to achieve that by 2030, there's a statistic out there that we would add 3.7 years life expectancy in low and middle income countries. And if those facts really hold, coming to the second reason you do this, it is just emphasizes again that right to health, that essential right to health. If something that simple, it's tough, not that simple, as you said, Minister Budi, but very doable, it is our obligation to ensure that we achieve that. But the third thing is, if we look back just over the last few years, even before we got into COVID, 1 billion people pushed into catastrophic expenditures because they couldn't access the most basic of health. And if I remember the stats correctly, again, 400 million of those pushed into poverty, just trying to access basic health services. So extraordinary reasons to your question, Sarah, WHO's focus now on the reorientation of UHC toward primary health care. This will be our big drive over the next 5 years. In doing that, we're not naive to the challenges in front of us. And again, Minister, thank you for your speech, which laid those out for all of us. But whether it's the financing, whether it's the workforce, whether it's the integration of services, the coordination, all big challenges in front of us, but all very much doable as we're seeing, or addressable by country after country that's tackling this agenda. And just delighted by the range of speakers that we have here, because I'm going to sit down in a second and learn from those people. But we've got some great experiences to be sharing and learning from on this agenda. Because as we go forward, and this is where WHO's emphasis will be, first and foremost will be the convening around what's working, what's not, getting the political momentum behind this. And we have the high-level meeting coming up again, of course, this in September, which will be another opportunity to boost this. A big focus on the workforce issue. Without the people in the right places, with the right skills, properly paid, we just cannot move the agenda as well. But there's new things we can take advantage of course, and another big thrust from our side, again, you alluded to it, Minister Budi, is the digitalization of the sector. There are new tools that we have today that could help us move so much faster, shine bright lights on where the gaps are as well, and try and address them that much faster. So another big thrust that we're working with so many of the countries here today. And the final one that we're very, very focused on is the fundamental of financing and investing in health. Now we're looking and moving our capacities at WHO to not just helping provide the normative, the technical advice on how to move the agenda forward, but to help countries put in place investment plans, compelling investment plans that help make the case for this to the bankers and to the leaders, but then also to be sure that in doing so, we leverage and coordinate all the many financing sources, private, public, that are already part of this agenda. So, Minister Budi, just to close, I want to sit down and listen to some of the experiences before we have to dash off to this meeting. I forgot the name of that's going on up the hill, World Health Assembly, that I'm a little part of. So I'll have to dash. I won't hear all of what's going to be said today, but I'm very, very keen to stay abreast. And again, thank you, Minister Budi, for bringing us together to discuss this issue. Transforming UHC to a primary health approach, absolutely crucial. And it's not, as you started with, Minister Budi, health doesn't start in hospitals and clinics, right? It starts in our homes, starts in our schools, starts in our workplaces. It's about the food we eat, it's about the air we breathe, the environments we live in. And that is what primary health care is, what our agenda will be going forward. So I'm going to sit down and listen to you, some of the examples of what's working, what's not, and how we, WHO, can help. Thank you.
Thank you, Dr. Elworth. Now I would like to invite Ms. Anna Stavdal from WHA to to address the role of family medicine as the key drivers of the integrated primary care services.
Thank you very much, and a very good morning, Your Excellency. Thank you for your introductory remarks. It fits completely with my take-home message, which is, if you want a healthy population, give people family doctors. Thank you also for inviting WHA to co-host this event. You are actually putting primary care on the agenda of the biggest marketplace of global health policies, the World Health Assembly. Thank you and congratulations. I have a few slides. This is from my practice in Oslo, Norway, where I have practiced as a family doctor, university teacher and trainer for more than 30 years. Next slide, please. We are here to reconfirm what was just said. Our commitment to strengthening primary health care, because we know it's the prerequisite to reach universal health coverage. We have the evidence that more than 90% of a person's health needs can be covered by primary health care. Primary health care is teamwork. I will explain why family doctors are key to maximize the potential of the primary care team. Next slide. It's intuitively easy to understand what heart surgeons, neurologists, and gynecologists do. Their approach is defined by the organ system of their specialty. Family medicine is in its nature fundamentally different. It's not disease-oriented, but person-centered, and has its own curriculum and research base. And it is based on a set of values. Next slide. Family doctors work in different political systems and different health systems, and our local context can look different. Guatemala, Nigeria, Indonesia, and Norway. But we have the core values in common. We deliver personal, continuous, comprehensive care in the community. Next slide. Values might sound pretentious, kind of soft, but I will give you some hard evidence. This Norwegian register-based observational study of more than 4 million patients and their GPs went viral when it was published in the British Journal of General Practice in November 2021. Conclusion: the length of a regular GP-patient relationship is significantly associated with lower use of out-of-hours services, fewer acute hospital admissions, and lower mortality. The presence of a dose-response relationship between continuity and these outcomes indicates that the associations are causal. When the relationship lasted for more than 15 years, these occurrences were reduced with up till 30%. That's something for banker. We are speaking numbers. Next slide. How can this be explained? I mean, medical conditions do affect each person differently. These differences between us reflect who we are as individuals, physically and emotionally. And the personal relationship is the basis of trust. Trust makes you share information which you wouldn't volunteer to a stranger. Information which can be crucial for diagnosing and tailoring treatment of disease. You are also more likely to follow someone's advice if you trust them. We have seen that clearly during the pandemic. In family medicine, prevention and treatment of disease go hand in hand. Next slide. For health policies to be effective and efficient, they need to address local needs. Societal change is always reflected in healthcare, and first of all, in primary care. Family doctors have ears to the ground and observe the impact of societal change, but also of health policies, the impact of health policies. Useful knowledge to policymakers and politicians. Research takes time. Reports from the field can be delivered without delay. Next slide. With the right skills, family doctors can tailor treatment and contain people in primary care, avoiding unnecessary referrals to secondary care and unnecessary admissions to hospital. But training is needed. The Lancet Commission of 2010, the health workforce for the 21st century, concluded, in order to meet future health needs, 50% of the health workforce should be trained for primary care. Next slide. The knowledge we hold reconfirms the conclusion of the vast research space of the late Professor Barbara Starfield. Continuity of a personal relationship with a freely chosen primary care doctor over time accounts for better health outcomes, and much lower costs. Next slide. On this background, Wonka says, now more than ever, what the world needs is high quality primary care, a close to home healthcare hub that functions in seamless collaboration with social care and public health services, as well as with hospitals. That requires strong interprofessional teams with family doctors. Thank you for your attention.
Thank you, Ms. Kafdal. Next, I will call Dr. Atul Gawande from USAID to present a lesson learned from USAID projects on transforming primary healthcare.
Delighted to be here. Thank you, everybody, and thank you, especially Minister Budi, for your friendship, your partnership, and your championing of this work. Very strange. The banker and the surgeon are here talking about primary care appropriately. Anna is the right person to present the data. First of all, I am leading global health at USAID, where we are traditionally providing investment in vertical disease-based services, and that is HIV, TB, family planning. We are a major world investor in preparedness against future pandemics, stopping outbreaks. We are doing work in nutrition, and what you will see over and over again, as I came into this work a year and a half ago, is that virtually all of it is delivered through a single team, and that is the primary healthcare team. We are now 3 years into the first reduction in global life expectancy in more than 70 years. And the damage that was done was not just from the coronavirus directly killing people. The damage was done with the diversion of resources away from essential primary healthcare services. The damage was done because of economic damage to especially low and low middle income countries, where the space for financing for healthcare has shrunk enormously. And then the result is a loss and a disabling of the available workforce for primary healthcare. That's resulted in some of the lowest levels of immunization we've seen in years. 67 million people, the UNICEF reports, went unvaccinated. We have seen, therefore, not just that, we've seen flattening or falls in survival for child mortality and maternal mortality progress. We've seen that efforts to address non-communicable diseases have been practically stalled. So the thing I want to add to what has already been described is the urgency of needing to address primary care right now. It is critical in order to recover mortality, in order to get back anywhere to being on track towards the 2030 goals of advancing survival. We need to make investment in primary health. Our goal should be, at minimum, to recover to better than pre-pandemic survival levels by 2025. And we've been arguing this at the US on the global stage to embrace a concrete goal for where we would need to get to. You cannot do that without recovering essential health services, and you cannot recover essential health services without the focus on primary health. At USAID, recognizing we're in these verticals, that all of our disease programs end up wanting to invest in and investing to some extent in primary health care, but not in the concerted way that says, are we looking and measuring the health of our primary health sector? Part of what we've done is created something we've called Primary Impact, which is selecting 7 countries where we really tried to demonstrate the model of connecting the dots between essential health services and what the investments in primary care can achieve. We've partnered with the Global Finance Facility and the World Bank in these 7 countries so that USAID is investing alongside the country's plan, the country's financing, to have our vertical, often disease or condition-based investments serve the larger goals. And one of those 7 countries is in Indonesia. And I was just there in February visiting with Minister Budi. Why Indonesia? Well, as you just heard, these are all 7 countries where there's been a focus on a radical reorientation towards primary healthcare, as DG Tedros has outlined as a major priority in his 2nd term. And that is specifically recognized by the fact that you are, like many countries, taking World Bank loans to capitalize your domestic financing, but you've made the primary focus, the primary healthcare focus, the center of it. And you've already moved investment in Indonesia from as low as 10% of the budget for health to 25% being primary healthcare, with a goal of reaching 50% by 2025, which is extraordinary. It matches what you said about what percentage of a health system investments should be oriented in this direction. And we very much want to be partners in that. The last thing I'll say is one of the most critical takeaways from looking across a variety of work is that countries that achieve better survival than their economics have been ones that invest in primary health. The countries that do not have been underinvested in primary health. Countries like Costa Rica, Chile have had long decades of investment in their primary health networks. And the result of that has been 81 years survival. The US is less than that. And we ourselves have not had that same level of investment in primary health. Indonesia is a similar way, economically doing well, but survival is under its own economic capacity. And you are turning that around. We want to be partners in that, and we want to be partners everywhere that we can possibly learn to do that. I think we have to demonstrate on the world stage. We have been talking about primary healthcare on the global stage for 5 decades. So we have to make it investable. And in order to make it investable, you have to show how an investment in specific health workers, and it is team-based. It's not just having the doctor, as Anna points out. It has to be community health workforce, arguably at a nursing level or higher, able to touch every home at least once a year, and integrated into a primary health clinic system where needs that can't be met locally are directly, people are directly connected into that system. When you see that those investments translate into better health service coverage rates and better quality, and we know that leads to better survival, if we can show and connect those dots, I think we can make this next 5 years different from the last 50. Thank you.
Thank you, Dr. Gawande. Now we're going to have our sharing experience sessions. We're going to hear from 3 countries, Thailand, Canada, and Uganda. And this session will be moderated by Dr. Ismi from the Indonesian Family Medicine Associations. Dr. Ismi, the stage is yours.
Thank you, Bu Sarah, for the time. Our honorable speakers and then distinguished guests. We want to hear now about lesson learned from other countries that already implemented or in the middle of implemented or primary care, integrated primary care with the family medicine approach. And then for the first experience, that is from Dr. David Ponkat. Hello, Dr. David, are you there? Yeah, it's still mute. Yeah, it is 2 a.m. in Canada. And then, thank you so much for Dr. David.
Thank you. I just received permission to unmute. Nice to see everyone. I'm calling in from Canada. I wish I could be with you.
Yes.
Great to see so many friends in the audience. Hello.
Thank you, Dr. David. Dr. David is the director of the Besro Center in Canada and CFPC. And then Dr. David, the time is yours.
Thank you. Shall I share my screen or are you projecting the presentation? I'll share my screen. It's very nice to be with you all. Dear Minister, dear friends, dear colleagues, I'm calling in from Canada, and I am the lead of the Besro Center for Global Family Medicine at the College of Family Physicians of Canada. And indeed, it's a great honor to be speaking to you because the Besro Center's core mandate is to collate and share lessons between countries who are trying to transform their health system towards, as Dr. Gawande says, a more horizontal, integrated one. It's important to note that while the center is under the auspices of the College of Family Physicians of Canada, we are highly interested in interdisciplinary and integrated approaches, and I will be speaking about such approaches. Let me start with a land acknowledgement. And it is important to note that there is a wise worldview from peoples such as the peoples who settled this land that I'm calling in from, the Algonquin peoples, the knowledge that everything is connected. Today, we are living through the 4 Cs, the ongoing effects of COVID-19, number 1, the cost of living, conflict, and climate change. And health systems have to have interconnection and nimbleness at the heart of all of our efforts in order to integrate better. This is the logo of the National Gallery of Canada, by the way, where my wife works. And just like for primary care, one can see that everything is connected around a central axis. The Besro Center is in partnership with many countries that, like Canada, are transforming their health systems. Transformation can happen in many different ways, and we work with organizations such as WHA. We have an MOU with our friends at WHA, with the WHO, and indeed, we have welcomed fellows from around the world. Dr. Gawande mentions Chile. Our first fellow was from Chile, and she looked at interdisciplinary care and how to do that better. Our next fellow from Nigeria is trying to integrate mental health and primary care through family health models. And indeed, we will be welcoming a Francophone fellow from Madagascar. That's an important part of our mission, that of bilingualism and multiculturalism. Our fellow from Madagascar is an internist, in fact, trying to launch the discipline of family medicine in her context. Now, this is a map we recently published in Canadian Family Physician on the status of family medicine training establishment in the world. Again, family medicine is not the only discipline working in primary care, but it is an interesting proxy for people-centered integrated models. One can see that a lot of work remains to be done, and that recent conflict or divestment have led to educational programs being canceled in Afghanistan, Belarus, and Mozambique. On the bright side, Indonesia is now a color on the map. It should be updated from this publication. In February 2022, in Ganja Mada University, Yogyakarta, and in August 2023, in a few months, Siak Kuala University, Banda Aceh will have launched family medicine programs, and that deserves a great round of applause from us all. I can see you clapping, I can't hear you. We've all seen these multiple waves by Tseng, representing the ongoing waves and how they are interconnected. What's important to note is that family medicine is inherently interprofessional and community-based to be able to respond and pivot between these waves in a nimble fashion, back and forth as we oscillate and as we will oscillate in future crises. The Besro Center has created free modules to use around some of these waves, and they're available at fmpivot.ca. Dr. Clayton Dick, who's in the audience, has been creating these and will be creating a series of podcasts that will also be free to use. So please stay tuned. Now, this is a drawing from my eldest, Ella, who takes her artistic talent from her mother, I assure you. And it's an important reminder of the difference between multidisciplinary, interdisciplinary, and transdisciplinary. Let us all hope for a transdisciplinary future one day, as the minister says, where every project and every law will be for the betterment of the human condition. But for now, let us at least work towards interdisciplinary care, where physicians, nurses, community health workers, allied health are truly working together and not just in parallel. That's too often the case, including in Canada. I work with nurse practitioners who see their own patients, and we work in parallel rather than sharing lessons and strengths with each other. This is the most important slide I wanted to show you, some very recent data from our FMVAC study, which was funded by the International Primary Healthcare Research Consortium, and we collaborated with WHA on this, and shows how increasing perceived primary care public health integration on the x-axis contributed to vaccination rates on the y-axis. You can see clearly that economic inequities contributed the most to vaccination rates, and even as recently as this morning, only 30% of people in low-income countries have been vaccinated with even one dose. That's a travesty. But one can also see that the system and the integration of the system led to more successful campaigns regardless of income level. We can also see outlier countries who did this particularly well, including Indonesia, and who can become regional leaders around health system integration. Congratulations again. The Besserer Center is proud to be working with some of these countries and critically learning from you about health system integration. I will finish with similar remarks to my friend Anna Stavdal, and that is about trust. Integration between primary care and public health to give a robust primary healthcare system is something that we are all still learning to do. We can see how interdisciplinary models, whether we call them patient medical home, community-oriented primary care, are key. Horizontal integration, this is all key. But an ongoing area of interest, I'm going to leave us with a challenge because that is important, is how to maintain continuity of care and trust through such models. How to maintain person-centeredness, also with digitization of health technologies. How do we do this? And not only promote anonymity for the sake of so-called efficiency. We know that continuity of care, as Anna has said, improves overall health, preventative care, quality of care, adherence, satisfaction. For the policymakers, it's critical to note that it also reduces utilization, mortality, cost. But also critical at this time is that continuity of care and family medicine models weave physical and mental health seamlessly. And we are seeing ongoing effects from the COVID pandemic that require more and more mental health integration. At the Besserer Center for Global Family Medicine, we're very proud to be launching some projects around mental health integration, and I look forward to continuing this work with you. Thank you very much for your attention, and I wish you a very successful and meaningful World Health Assembly. Thank you.
Thank you very much, David, for the nice sharing. And then we can continue our meeting today with the Ministry of Age from Thailand.
Can I sit here? Yes. Excellency, distinguished guests, ladies and gentlemen, I'm Dr. Sura, DG of Health Service Support from Thailand. Thank you for inviting Thailand to share our experience on primary health care. There are three phases or pathway toward people-centered PSC in Thailand. First, about the infrastructure. Building up PSC infrastructure since 1970, the Ministry of Public Health built up sub-district health center and district hospital, which had reached 100% cover. We have about 10,000 health center and 800 district hospital and 200 general hospital. The network of sub-district health center become PSC infrastructure for Thailand. So the most important thing that adequate health workforce training and deploy made PSC functioning. Ministry of Public Health, we have more than 40 colleges to produce nurse and healthcare worker, maybe 50% ago. And the second, in parallel of infrastructure development, 3 major integrations have been achieved at PSC. Service integration, that means prevention, health promotion, disease surveillance, treatment, and rehabilitation comprehensive provided by PSC. During P and in-service health workforce are trained to develop this competency. Integrate level of service. This means level up and down between PSC and secondary care and tertiary care. This is to ensure continuity of care, including home care and visit to home and bed-bound patient by health center. Integrate multi-sectoral with local government in order to address the social and commercial determinants, major risk factor in the community. The National Health Security Office and local government establish sub-district health fund for the community to solve its health problems. Thus, introducing family medicine into PSC in 2017, Constitution which mandate the development of primary health care led to the legislation of the 2019 PSC Act. So by this family care team consists of family doctor at district hospital, health workers at the health center, and village health volunteer responsible for 10,000 population. This means a target of the 6,500 team nationwide to be deployed. This is a major breakout of Thailand health system development. By now, we have about 3,500 team since 2017. So maybe more than 50%. First, in summary, key contribution factor. First, political commitment and leadership, long-term policy concurrence in support of PSC across series of government. Second, high quality health workforce with full application of rural retention policy. WHO recognized the significant contribution of over 1 million village health volunteers in support the COVID retainment as a effect in Thailand, universal health and preparedness review. Third, PSC is the main contractor provider network for universal health coverage scheme. This ensures a steady flow of funding in support of PSC capacity and functioning. Fourth, application of innovation and technology, especially during the after pandemic. More than 700 retinal camera are available in PSC to online submission to retinal photo for AI reading and detection of diabetic retinopathy. Finally, multi-sectoral engagement in support of PSC, especially by social government and municipality. These are lessons learned from Thailand I would like to share with you all. Thank you very much. สวัสดีครับ
Thank you. The very interesting lesson learned from Integrated Primary Care Service and the role of family medicine from Thailand. And then the last one, we will listen about the lesson learned of Integrated Primary Care from Uganda. Dr. Innocent, are you there? Hello, Dr. Innocent. Dr. Innocent Besinye?
Yes, hello.
Oh, yeah.
Let me share my slide.
Oh, yeah. Please, Dr. Innocent, the time and screen is yours.
Yeah, thank you very much for the invitation to present at this side event. My name is Innocent Besigye. I am calling in from Kampala, Uganda in East Africa. And I will be sharing about the lessons we have learned from Uganda as far as transformation to integrated primary care services is concerned. And I will specifically focus on the role of family medicine. Just to give a short brief background on Uganda. Uganda is a low-income country in East Africa, so our gross domestic product per capita is just slightly above $1,000, and we so far currently have a population of about 46 million people. And when you look at that, the doctor-patient ratio now stands at 1 doctor for every 25,000 people. And it is important to note here that we have less than 100 family physicians. So in some way, we now have 1 family doctor for every 1 million Ugandans. And in terms of our health system, we have a 2-tier health system where we have the primary care services that are under the district, which is controlled by the local government. And here, the local government is the overseer, but again, it operates within the health policy and the framework designed by the Ministry of Health. And then the primary care services form the foundation. So after the district, we have regional referral hospitals and tertiary referral hospitals, which are under the stewardship of the central government under the Ministry of Health. And it is important to note that we have private health providers who are also important key players in the provision of primary care services. Now, specific on the reorientation of primary health care and the role of family medicine, some of the approaches that the country has instituted to strengthen primary health care is through policy formulation. And there are so many policies and guidelines and documents that guide the implementation of primary health care, but I thought it is important to mention these two because the health policy is the overall document that guides the health system. And therefore, it's operationalized by another document named Health Sector Strategic and Investment Plan. And this is the document that guides investment on health. And in the country efforts to reorient its health services to PHC and integrated services, both these documents are based on primary health care. And therefore, they provide a framework within which the health system operates. And of course, there is no proper orientation if you don't have the workforce. It is the people who make the things happen. And therefore, we have a 3-year postgraduate program or residency program that trains family physicians. And so far in the country, we have only 2 training programs. So other universities have not taken the training programs on, but we are in constant engagement to also help them start on the training programs. But it's also important to note that it is not only the doctors who train as the PHC providers, but the PHC workforce includes other cadres like the clinical officers, or the mid-level health workers, and the nurses. And then PHC governance. As I said before, primary health care is under the stewardship of the district health system. And therefore, we use a decentralized system since 1995, where the district is in charge of the planning, budgeting, and implementation of primary health care. And this approach helps in making the services to be responsive to the needs of the people, because the district managers or administrators, they are the ones who are really fully aware of what the health needs of the local population are. And therefore, in planning and budgeting and implementation of PHC, that is what guides them. And again, being a low-income country, we know that we don't have all the money with us to provide everything. So the government designed the Uganda National Minimum Health Care Package, which is a package of essential services which are provided by primary care facilities, and they should be accessed by every citizen at no cost. And when we are training the primary care providers and particularly the family physicians, we actually make sure that they are competent and skilled in the provision of this minimum health care package, which basically includes mainly the curative services. As you heard the minister talking, many of us are still heavily oriented to curative care, but it also includes the control of communicable and uncommunicable diseases, maternal and child health, among others. Now, within this situation, what is the role of family medicine? Basically, the family physicians provide the clinical services. And here we know that every clinician provides the clinical services, but the key ingredient that comes in, like what Dr. Anna Stavridil has mentioned, is basically the core values of family medicine and the core functions of primary care, which include first access, first contact access, continuity, comprehensiveness, coordination, and person-centered services. And this, particularly for the countries like Indonesia, where they are just starting the training program and reorientation, it is important that many family physicians who will be trained should be in clinical services, because what happens in the countries and what we learned in Uganda is that the first graduates are likely to run into offices to manage health services and also become managers of the ministries of health. The provision of clinical services by family physicians makes sure that the potential trainees will see family medicine in clinical action, and therefore they act as role models, which is an important driver, the scaling up of the training of family medicine. And also, we know that leadership and management is important if you are there to orient any health system. So most of the family physicians in our country are also managing health services, ensure that quality primary care is provided. And they do this in both public and private settings. But there are also a good number of family physicians are managing district health system as the district health officers. And some of them also manage lead health organizations, as it is common in most of our countries. There are many health organizations, and most of them are led by the family doctors, where they also provide leadership and management. But it's important to also know.
Yeah, excuse me. Yeah.
Hello?
We time enough. Yeah. Yeah.
Yes.
We only have limited time. Yeah. Thank you. Can you conclude the presentation?
Yes,
because
so in conclusion, is that
yeah.
the lessons we have learned is that training programs for primary health care workforce are needed. And if the training programs, the lesson we have learned is that you need champions, and in most situations where countries are beginning, we actually, these training programs are started by non-family physicians. And you also need to have primary care friendly policies, which will enable strong PHC with integrated primary care services. And these don't just happen, so we need the champions. And it's also important that we leverage on subnational, national, regional, and global networks, which will be helpful in trying to learn what has worked and what hasn't worked in other settings. Thank you very much.
Thank you, Doctor. Yeah. Thank you very much for all the presentation and sharing from countries, from Canada, and then Thailand and Uganda. And then because we have so limited time, because our Minister Budi will leave us, I think Bu Sarah, yeah. We do not have, but Pak Budi, do we have a time for one question or discussion?
Okay, just let open it up for one questions or two questions. If I have to run, then I will say thanks a lot. By the way, I don't want to disturb your enthusiasm. In Indonesia, we believe that family doctors would play a significant role in preparing our people not to become sick. And thank you for coming. But if there is any question from the floor while we are having Anna and Atul, maybe we can have one or two. please.
Please. Is there any question or we can discuss something? Oh, okay.
Hello, good morning. My name is Professor Bettina Borisch. I'm the CEO of the World Federation of Public Health Associations, closely working with WHA, because as mentioned by Anna, public health and primary care physicians, I think, have to really work together, including social workers. I would not ask a question, underline what you have said, Minister, and ask ourselves, why took it so long since Alma Ata? Why have we been not progressing? And what could we do to accelerate? It's a question to all of us. I think that also we ourselves are a little bit furtive, because the policy of knowledge that we distributed to our people should be changed, and not telling them that only the specialists, so-called, can do it. Perhaps change the policy and get our populations on board with another story, with a story, health is important. And if you want to stay healthy, with whom do you stay healthy? Not the one that is operating your heart. He is important, but that is really a late resource. You want to avoid him. So my call to all of us, let's speed up the policy of knowledge that we have been running till now. Thank you so much.
Okay. No, last one, please.
Okay. Is it okay?
Yeah, okay. Last.
Thank you so much, Minister. I'm Bo Elias, and I'm Director of Health at the Copenhagen Institute for Future Studies. I'm really inspired by your work. So I have one very simple question, and for the rest of the world to learn. What was the single most important thing to, not to think this change, but to make this change?
I learned something in COVID. It's very difficult to execute 410 million doses to more than 205 million Indonesians in 18 months. I learned something, and I talked to my people. The approach that the healthcare system intervention, especially when you're talking about public healthcare, you shouldn't create a programs. You should be able to establish a movement. It cannot be exclusive, but it has to be inclusive. It is not about how I will lead, but how about everybody will lead. So I said to all of them, yes, we have 300,000, 300,000 times 5 or 10, 3 million community workers. But my dream is, especially in Indonesia, because of the culture, it has to be sensitive culturally. If I can train every mothers in Indonesia, so maybe we have 100 million, 150 million mothers, because by nature in Indonesia, mothers take care the healthcare of the families. When the children sick, I'm sorry, it's not the father. I'm not trying to be sexist, but it's not the father. It's the mother who take care of the children. Even if the husband is sick, then the mothers will take care of the husband. So for me, we have to be able to create a movement educating all mothers in the country how to take care of the people. And if you reach your certain limit of knowledge, you go to the family doctors, because then we have doctors, we have family doctors in every household and every houses, and they will definitely do it with passions, with love, with compassion, and we can establish that movement inclusively. That will be a success of our primary healthcare. Healthcare is not my program, the government program. It should be owned by each individual people. When it's owned by them, then I do hope we can live 90 years, 95 years, or whatever, maybe 100 years, the centennial. Thank you. And thank you for all.
Okay, thank you. I know there's still enthusiasm for question, but I'm afraid Minister Budi needs to leave. So thank you everyone who spare your time to attend this meeting today, this morning, in person, and as well as the one who attend virtually from Zoom. So thank you very much and good morning, everyone.